Next, I'd like to welcome Terry Slevin from the Public Health Association of Australia. He's going to talk to us about sort of 5 years on, looking at next steps and priorities. Adjunct Professor Slevin is a regular media commentator on all aspects of public health and cancer, ranging from causes and early detection to broader chronic disease prevention, including nutrition, physical activity, weight control, alcohol, sun protection, and even gun control. Professor Slevin holds a Master's in Public Health and honours in degree in psychology, as well as serving as the chair of the Cancer Council Australia's Occupational and Environmental Cancer Risk Committee. Mr. Slevin has previously chaired Cancer Council's Skin Cancer Committee, and was the founding chair of Nutrition and Physical Activity Committee, where he served for 10 years. He's contributed to the planning for the Union for International Cancer Control and the World Cancer Congress from 2012 to 2016, and was co-chair of the Scientific Committee for the World Cancer Congress in Kuala Lumpur in 2018. Welcome, Mr. Slevin, to the stage.
Thank you. Thanks very much. I was just saying, I feel firstly greatly privileged that you're all still here. I was mentioning to John that I think I've run about 25 conferences over the last 5 years, and the fact that you're still here for the final session is testimony both to your commitment and to the organiser's skill of putting the show together. But before I go too much further, I want to acknowledge the traditional owners of the land we're meeting today, the Gadigal people of the Eora Nation. I grew up north of here on Awabakal country. I've lived on the west coast of this great island in the land of the Noongar people, and I now live in the land of the Ngunnawal and Ngambri people, otherwise known as Canberra. I'm greatly privileged for the invitation, so Russell, thank you for the phone call. I was sitting looking at Lake Burley Griffin, taking a bit of a break in the middle of the day for a bit of a mental health rest, while eating in my car because it was too bloody cold in Canberra to get out. And Russell, who I'd never met before, kind of spin this yarn to me, and I said, well, Russell, I'm in Sydney the day before, so if I can help out, I'm happy to do so. And so I start with a really important slide, and that's a disclaimer. And the disclaimer is you're the experts in this topic, not me. I don't pretend for a moment to be a mental health professional or expert in any way. And so thinking about and delivering this talk was very daunting, I have to say. Because I'm very conscious that there are respected protocols, language that you use that's been carefully debated over many years to ensure appropriate respect to all of the participants, all of the expertise, the people with lived experience. And this isn't my world. So I'm going to ask you in advance to forgive me if I stumble into inappropriate territory. So, but also in thinking about that, thinking about the fact that I've been talking about health for 40 years. And there was a level of anxiety in my little soul that said, this ain't my patch. I'm not sure I know how to talk to these people. And that by itself tells me something. And we saw the slide yesterday about the severed head, the treating the head versus treating the body. And I still think that's a fundamental problem with the fact that me, with 40 years and the experience that I've had, has a kind of an abiding anxiety of having confidence to talk to you people. I want to learn, and I'm sure, and I have already learned more than I suspect in part. So thank you for allowing me to come along. I was able to sit in the session late yesterday with Joe coming in from Manchester and some of the sessions this morning. But it's kind of reinforced my thinking, and so I'm going to deliver a few messages today. I hope they're constructive and useful because I bring a public health toolbox. Of all the people in the room, happily I've got a history with one. Jenny Bowman's over there. Jenny and I did undergraduate psychology together. She must have been a child prodigy of about 9 because it feels to me like it was about in 1857. But Jenny was much smarter than me. She always got high distinctions and I was badly behaved at the back of the classroom. And has gone on to have an outstanding career in public health that's worked into the mental health area, and I'm sure I can learn a lot more from Jenny. But I have kicked around the public health world for quite a while, and my role in Canberra allows me to go up and visit the big house. I've got one of those orange lanyards, which allows me to wander the corridors of Parliament House and meet the politicians and stop them in the corridors. The term lobbying comes from the fact that you actually do meet them in the lobby as they walk across from picking up their coffee at Aussie's back to their office, going across from their office into the chamber, etc., etc. And I do that. I bowl up to them and start having a chat. And it is the most fun you can have with your pants on, I've got to tell you. For the simple fact that you learn that these are people who do, like you, they put their strides on one leg at a time, and most of them genuinely want to do good things. Now, you've got strong opinions about politicians, everybody does. But my experience is, regardless of the side of politics, and there's some that none of us like, okay, I'll accept that, and there are some duds, but the simple truth is most are there for good reason. Well motivated to want to make good things happen. Emma McBride came here on Tuesday morning. Lovely, lovely woman, pharmacist, mental health specialist, worked at Wyong Hospital, has worked at various public hospital pharmacy roles. There's a genuine commitment, I think, in the mental health field. And I think she is and will continue to be a wonderful minister in this space. But one of the things I've learned is that getting action in government is tough because there's genuinely enormous competition for attention, for resources. And that's the point where I want to deliver one of my key messages today. And that is, you've done extraordinarily well as a mental health community to make the progress that you've made over the last 10 years. And I've observed that as a player in the kind of health space. It's undoubtedly the case that there's been enormous progress over the last 10 years. So I'm going to ask you to give yourselves a round of applause because you genuinely deserve it. Look over your shoulder and recognise the progress you've made, and I'm going to encourage you to do that right now. So well done. I was going to start this talk with the kind of opening I give to a lot of talks, but I'm not going to do that. I'm going to talk about the investment in public health and how those funds have unfolded. And so I'm going to jump through about 3 or 4 slides. Those who want to look at it, it'll be online and available to you. But essentially it paints the story about how much funding is invested in public health. And when I talk about public health, I'm talking about largely the stuff before people go into hospital. If you want to think of it in simple terms, it's before people get crook. And I genuinely believe we need to be doing more about investing in preventive public health. That is, knowing and applying the evidence and science we have to reduce the number of people that get sick. Pretty simple concept. And we don't talk about it in simple terms, and we need to do more of that. This is just a capture of the expenditure of public health over the last probably 10 or 15 years. And the kick up at the end obviously is the start of the pandemic and the expenditure in the testing protocols and so on and so forth. And then it will probably rise again in the next couple of years when the introduction of vaccines and the like were brought in. But still, I encourage you to note from a base of, around 1.5% to 2% of health expenditure and kicks up to close to 4%. There's a commitment that was established by the West Australian Government through the Sustainable Health Review to aim for 5% for funding for public health in that state by 2029. It's the only jurisdiction in Australia that's done that. Hasn't done much to achieve it so far. And we've recently written to the Premier to remind him that that's the case, and we want to see that happen, and we'll be watching and we're looking for reporting to see that comes about. One jurisdiction that's committed to it, none that have done it. All are being encouraged to work in that direction. Some of that, if it is an additional resource in health expenditure, should go in mental health prevention and promotion, as well as efforts to improve the physical health of people with mental health conditions. Now, you've heard and I don't need to tell you all of the inequity, the difference in physical health outcomes for people with mental health problems, and we've been conscious of that for some time. So I guess really the guts of it is, so what are we going to do about it? There was a couple of presentations in here in the earlier session, and Andrew presented some of the work he's doing here in central Sydney. And my question was about how many mates he's got, essentially, how many other people are doing similar work. And I suspect it's very much leading stuff, and that's great. It's fabulous that work is being done. The challenge is how it can be rolled out to scale, and those are that's really the fundamental challenge of public health. There's lots of great examples of great stuff happening in public health around Australia, around the world. The enormous challenge is translating that to what we do for everybody. That's public health, that's population health. Here's some of the data that this is actually done by the Grattan Institute and doing a report on the Australian Centre for Disease Control. I'll talk about that in a few moments. And this is the data talking about, firstly, this is the chronic disease burden. You can see their injuries and then communicable disease. So in context, those chronic disease burdens, cardiovascular disease, cancers, diabetes, the ones you know about, a range of other musculoskeletal conditions and the like. And we know the drivers of those things. The drivers of those things we've been talking about: overweight, obesity, tobacco, high blood pressure, alcohol use, etc., etc. These are the things that we can and should be doing more about. We should be doing it for everybody, and we should be figuring a way of doing it specifically with people whose circumstance means they need extra help, they need extra support, whether that's because they're being discriminated against, whether it's because they've got addiction problems, whether it's because of other circumstances, which means that those population-based programs don't reach them in the way that they do for everybody else. I was involved in advocating for the establishment of and then putting together the National Preventive Health Strategy, and that's something that you might want to be conscious of. Actually, and before I go any further, one of the things that I have to tell you, and this is a confession, I'm not sure Russell and I made it, was when he started talking to me about this, I thought, oh, what's that? I only heard about it when Russell called me to ask me to come and talk about it. Now, that's my fault, not yours, but what it does is illustrate that there's a whole lot of work that needs to be done once these ideas, these notions, these documents, these well-argued cases then need to actually have an impact. It's what I call a sales process. You've got to sell your idea, and that's what I do in Canberra every day. Now, of course, in your sales process over the last 5 years, and this is meant to wrap up the conference, you've had a pretty big hole in the program called the pandemic, which has kicked everything into the long grass for at least 3 years. And I saw evidence from Andrew's presentation and other talks that I've seen that it's starting to come back to whatever business as usual is going to look like. But there's a whole lot more work to be done and bringing a whole lots of things together, and that's where I want to focus now. So the reason I was in Sydney was a conversation with the Australian Academy of Health and Medicine, just at an institution down the road at the University of Sydney. And we had a full day meeting talking about where this was going and what we need to do to actually make something happen, because this is in the same category as the Equally Well work, and that is great document, well thought out, evidence-based. So what are we going to do about it? So far, the answer is not much. So the challenge is translating into a reality. But within that, there's some specific recommendations and there's specific areas of focus and action. And there's been some progress. I mean, we know about the efforts in relation to tobacco and vaping, and this government has genuinely done what I call cut a path through the bush. It said, here's a package of measures that will genuinely shift the dial. It's not just one thing. It's not just a program to support cessation. It's not just a program to focus on Aboriginal and Torres Strait Islander smoking issues. It's not just lung cancer screening. It's not just regulation of vaping. It's not just taxation. It's all of those things in a combined, serious set of measures which will shift the dial. And on that front, and it's been mentioned a few times, and I'm very aware of you being conscious of it, ensuring that that is of relevance to everybody, and in particular focus of relevance to people who have high smoking rates and people with mental health conditions, and most certainly in that category. So the challenge is to translate not just that substantial piece of work where there is a commitment and some genuine head of steam, but in all of those areas, access to health services, physical activity, cancer screening and prevention, immunisation, and I've heard all of those things mentioned in this room over the last day or so that I've been able to participate. Well, actually, I'll go back. So, for me, in thinking about this, and the great opportunity to talk to you today has forced me to think about some of these things that I haven't wrapped my head around much in the last, really, few years. And that is, how do we prosecute these priorities while bringing on those with mental health challenges? How do we walk and chew gum at the same time? That's the challenge. Firstly, it is important to understand that you've got to focus on the whole population. And I guess the scenario I paint here is my first work in public health was in tobacco, and it used to be, and this is a long time ago, that the focus was, let's fix the kids, let's stop kids from smoking. And of course, we very quickly worked out the tobacco industry was delighted with that as a strategy, because they full well knew that if you talk to kids and say, listen, Sonny, you can't start smoking, that's bad for you. And Junior looks up and says, well, there's Uncle Fred, and there's, there's Granddad, and there's Mum, and they're all lining up. Why are you picking on me? People live within the community, within a society, and that drives people's behaviour. So if you pick one subgroup out of the community, whether it's kids or people with mental health problems or anybody else, and say, you need to fix this, they're going to look around and go, why are you talking to me? So a whole population approach is fundamental to the way I think about health. And I think that's fundamental to how we're genuinely going to make progress, and it's my belief that that's very much the case in most of the areas where we have genuinely made progress. But having ensured and established and embedded that approach, the second question is that how do you ensure that you capture everybody and make sure no one's left behind? And people who work at the population level have a commitment to that. We talk about that stuff all the time. The conversation yesterday at Sydney Uni about all this preventive health stuff, constant theme was, how do you do this in a manner that minimises inequity? That is, the difference between the haves and the have-nots. How do we do that? How do we embed that in the research programs? How do we embed that into the delivery programs? And that's where we need to learn from you. We need to have an open dialogue, a capacity where we can do our stuff better because we want to, and you can see the outcomes that you're looking for. But at the same time, what are the things that we've learned that might have an impact on the way you do what you do? It's a two-way street. And that's what's going to serve people the best, in my view. Within the National Preventive Health Strategy, there's also the need for promoting and protecting mental health. And I think there's a whole bunch of stuff in there. I think conceptually, this little capture of it, I'm not going to read you through it, but it captures a whole bunch of ideas, and I'm not sure it brings it together in a terribly coherent fashion. I get the sense that it's there because people felt it needed to be there, but I'm not sure they really knew what to do. So I think there's a whole lot more work to be done on that front. This is a really fascinating part of your consensus document, and I've grabbed a copy of it, and in preparing this I did read through it. And this struck me as a really powerful story to tell, but I crossed out a bit of the title of that particular table. The actual title reads, many factors contribute to poor physical health experienced by people with mental health illness, as outlined below. And I crossed out that bit. Many factors contribute to poor physical health for everybody. We're all in the same boat when it comes to that. And every single one of the factors identified here are fundamental to living a healthy life. And, I thought, well, if you want to get fussy, you could add a few other things. You could always think about these in slightly different ways. And I would throw in racism. I would throw in insecure work. I would throw in loneliness. And most people would also, if they, stopped and think, and we ran a quick workshop here, we could probably think of other things as well. But you understand the point. That is, we operate within a broader societal environment. We all do. Whether you're an Olympian or a person with a mental health challenge or an Olympian with a mental health challenge. So that kind of also, I think, became a really important kind of allegory, and this was taken from The Guardian a couple of days ago. We thought we were Australian. Melbourne Tower lockdown lives in legacy of trauma. So this was a kind of a story that really tells a bigger picture. And I was talking yesterday about the notion of an anecdote becoming an allegory. And I think the Melbourne Towers during the lockdown I think it was the first or second phase of the pandemic, really told that story about people of greatest disadvantage in terms of housing, discrimination, isolation, all of those issues, poverty, many of the other things, and I'm quite sure mental health issues, were captured by that one story of those people who were essentially locked up. And what's rolled on since then, anybody who's followed that story will know that there's been a $5 million compensation package that's been negotiated only very recently on that front as some means of recompense for their experience. So I think that experience has probably burned itself onto the soul of the health sector in Australia, and if it hasn't, then it should have. Now, I had a look specifically at this section within the consensus statement that you've come out with fundamentally equally well. And all of those things I agree with. But it's interesting the point at which it starts. The point at which it starts is first contact with mental health, with health and mental health services. I guess the case I'm putting to you is that health starts long, long, long before that. And we go back to that previous slide. And what are the things that we can put in place? What are the things that we can do to improve everybody's health that will have that broad benefit? I mean, it's certainly important to focus on the things that we control, and many of us work within the health delivery service. But it's also really important to think about what happens before then. So it's about not only to treat the problems of people who are addicted to nicotine or who are smokers. It's not only to help people who are in an overweight category to become a healthy weight. It's also about trying to prevent them getting into that position in the first place. And that's, again, equally important for everybody. And sometimes that's being unpopular. I worked in the cancer organisation for 24 years, and we did a whole range of stuff, and specific programs for people with mental health challenges were included in part of the things that we started. And this was now more than 10 years ago. I used to tell my crew, we pay you to be effective. We don't pay you to be popular. Sorry. Some of the stuff you do in public health is not popular. Increasing price of stuff is not popular, but guess what? Makes a difference. You can see that with tobacco. And we can have an argument about whether that's a legitimate or even moral way to influence the tobacco landscape, and I'm open for that discussion. But we do know that it works, and it works differently for different populations, and the addiction aspect, it's more influential and impactful on people on low incomes and so on. But as part of a package of measures, we know economics works when it comes to pricing. Even availability, the fundamental idea of what food is available. And I went and raided your box. I hope it's your conference, but there's a box out there with some fruit, so I pinched an apple for the car on the way home. Thank you very much. But it's just a simple illustration of availability of healthy food versus availability of unhealthy food. Walking the talk. Really interesting challenge when we were at my tobacco control program in Western Australia. We saw this important function of addressing those people who had whatever challenge it might have been, mental health, discrimination, etc. And the program looked at the drug and alcohol sector and going into the policies of the drug and alcohol sector and the phenomenon of, sitting down with a client and having a smoke and having a good chat as a way of engaging, as a way of starting a difficult conversation. Now, I understand how that's evolved, but is that the kind of message a service or a facility of that kind can and should be sending? Or should they be joining that movement to smoke-free areas? You can't smoke in this building. Many and many other places. What signal does it send if you're in a health facility changing the rules because whatever reason? Because that's the way it's been done before. So again, those kind of challenges exist as well. But also walking the talk in terms of policies about alcohol consumption and serving alcohol at conferences and so on. That's one that we've put in place in the Public Health Association, and most people accept it pretty readily. But there's always some pushback, mostly from my friends in the communicable disease sector, which is another interesting story. But there's also issues about challenging the things that are going on within society. The advertising and marketing of vaping, walk around this district, I still see signs up for vaping products around the place, etc., etc. Gambling, junk food, the availability, that is washing our system. Now, actually what I'm going to do is quickly jump through because I want to do this one and then go back to the other one. And now that I started talking about those environments, This is an extraordinary example of a public health policy. Well, it's a public policy that's gone absolutely desperately wrong. Australians are the biggest losers in the world. The biggest losers in the world by a very long way when it comes to gambling. It's a national shame. It's a disgrace. And yet we allow that to evolve because lots of people are making lots of money. And corruption is at play. Government policy has been corrupted. In this state, the last state election, there was two sides offering different policies, and the one that offered the worst policy on poker machines won the election. Money talked really loud. And who's putting their money down the neck of the pokies? The most vulnerable people in New South Wales. To a stonking degree. To a disgraceful degree. And it's all okay because it keeps the clubs going. And it's all okay because it might create jobs. Bullshit. It's wrong. It's morally wrong. And we have got this desperately wrong. So I'm really keen, and you know better than me the roll-on effect, the impact for people with mental health issues and the like. Taking money out of their pockets that should be spent on things that are far better for them. Sorry, I'll stop ranting about that. That's one of my hobby horses. But the numbers are there in terms of, just to simply make the point, per capita market, think of it in those terms, who's making the money, to the nearest Australian dollar, 332 per Australian per year. And there are many, many, many people who are in thousands and some in the tens of thousands of dollars. So this is just on a per capita basis. Australia way out in front. If you ran one of the international swimming meet races by this margin last night, then people would be lauding you as a national hero. Sweden, Ireland, Finland, UK, Denmark, way, way, way behind the amount of money that Australia... This is just online gambling. And we know there's different policies across different jurisdictions with regard to pokies, and I'm happy to talk about more detail about that. So this is an example where I think this is a mental health issue. So we need to get better at talking to you, and we'd really welcome you getting on board with us, because together we are stronger. Now, I'm going to talk about another opportunity that's come up only last week, and those of you who've been watching will have seen the wellbeing budget announcements that was made last Thursday. And I think this is an extraordinary opportunity for public policy in Australia for all of us who want to make the world better. We're all we all want to save the world one way or another. In your own particular sphere, you want to save the world. The people closest to you, your community, whether it's in central Sydney, whether it's policy that affects all of the people in New South Wales, whether it's national policy, whether it's the people just in your facility. But all of that is driven by the resources that allow us to do that job. And if we have a fundamental rethink about the way public resources are applied in Australia through this framework, we will be a better place. It's not going to be quick. It'll take years, probably decades. We've got a government that's probably got at least 2 terms in them, maybe 3, maybe 10 years. But the thinking coming out of Treasury that thinks about the outcome for the health and wellbeing of the community and frames the allocation of resources through that channel, bring it on. But these are the Treasury. These are the economics boffins. They need your help. They need our help to get this right, to make it better. When it first came out, there's the usual political rock throwing of the data's old and the metrics aren't right and whatever else. The Treasurer himself, and I have genuine belief he means it, is saying this is the start of this conversation. Sure, we can get better, and we welcome input. And I genuinely believe this government does welcome input. So we need to find ways of doing that to help sharpen the outcomes that they're going to measure, which will sharpen where they allocate the resources to achieve those outcomes and put some mechanism in place to measure the extent to which they make progress. It's a simple concept. It's tough to do, but it's a genuine opportunity and I'm really excited by it. But, as I was preparing this talk last week and it came up, I thought, that's a key idea, but I'm not across the detail anywhere near the extent to which I want to be. I just want to throw one other notion at you, and I'll rant until you tell me to stop. So, think of how many economists there are. One might argue, and if anybody of you have got kids and they're studying and you want to encourage them to study somewhere where they're going to get a job, encourage them to study economics. There's a big demand for economists. So it's probably not enough economists for the demand that exists. Within that, very few of them have a focus on health. And those who do focus on health, the health economists, primarily focus on where most of the money's spent, and that's in the treatment sector. So the economists who know about health and public health and prevention, there's literally probably about 6 or 7. There's not many of them. But it's a sphere of expertise that needs to play into this framework to genuinely make a difference and shift the dial. So that's something I'm excited by. Those are some of the measures that I've been identifying and some of the things you've been talking about today: access to care and support, access to health services, life expectancy, we were talking about that this morning. Mental health is in there as one of the 5 things they've identified, and so too is prevalence of chronic conditions. So this is actually really directly in our wheelhouse. And you might not feel confident as an economist in the way I might not feel confident to talk to mental health experts. But having an understanding of this, thinking about it and helping to form the ideas is a really, really important opportunity. I've ranted about it, gambling. I'll jump over that. Okay, what's the next opportunity? This is a piece that my president and I wrote in our journal, Australian New Zealand Journal of Public Health, in 2021, yes, about the notion of establishing the Australian Centre for Disease Control. And out of the pandemic, it makes sense that Australia doesn't have one, should put one in place, and that was a Labor Party policy prior to the election. So they did commit to establishing a CDC. You might say, so what? Well, because it includes specifically ensuring ongoing pandemic preparedness, lead the federal response to future infectious disease outbreaks, and work to prevent non-communicable or chronic diseases as well as communicable and infectious diseases. And that's not just for the fittest, the healthiest, the wealthiest Australians, that's for everybody. And it should have a focus on equity. And I believe that the wording and the intention will be that it does. The challenge is to figure out how to actually make that happen, how to make that rubber hit the road. So that's again the opportunity. Final message I'll send you is that we're also wrestling with this in terms of even mental health promotion and prevention and what that really means. And I think there's a strong movement that's started in that sphere, and you may well be a part of that. I think with the crossover of mental and physical health, I think those things are fundamentally important and connected as well. So within my shop, the Public Health Association, we've got about 2,000 members. We're a tiny show. Annual budget of probably no more than $3 million. We run conferences, a whole range of public health issues, and you can appreciate the diversity of what is under the public health banner. And we've got 18 special interest groups, SIGs we call them, and one of them is a mental health SIG. And we were talking with them about the notion of bringing together the people with an interest in the prevention of mental health problems in the first place. And like physical health, my observation is a lot of the resources in mental health are invested in treating those people who have a diagnosis, and that's understandable. But wouldn't it be great if we carved out some focus on preventing people going into that pathway in the first place, and what we know about that and what we can do about that? That's what this conversation is about. We're having a one-day symposium in Melbourne in March. I was involved in the planning meeting on Tuesday afternoon before I jumped on the car to drive to Sydney. That's forming up really well, and that's an area that we're committed to try and advance as well. So that's just one of the things that we're looking to try and advance. There is enormous overlap between what will happen there, the kind of things that you've been talking about here over the last couple of days. And as I guess a final message for me, and I was asked to answer the question, which I suspect entirely unqualified to answer. What's next steps and priorities? And here's just my take, and that's all I can offer you. That is, firstly, focus on building better health, public health capacity and infrastructure that serves the entire community. Not only so we're better prepared to deal with the pandemic that's around the corner and the next variation of the next virus, and that's fundamentally important. And if we get that right, that's going to benefit everybody, regardless of your mental health status. Second thing is build a better bridge between public health and mental health peoples. Our communications, our language, our common goals, remove some of the anxiety and reticence to talk to each other in the fact that, we don't want to feel like we're going to stumble across each other. We have a common objective, we have a common goal. I genuinely believe that people in the public health world are running the programs you've been talking about: tobacco, alcohol, cancer, screening, immunisation. We always talk about ways in which we can reach the underserved populations. But we need to learn from you. So how we can build that bridge, how we can make that happen, those are the things that I'm really keen to see. And that's what I'm seeing, the work that you're doing. And from coming here today, I've learned some of that in the Equally Well work, the stuff that Russell was talking about this morning in terms of the database of interventions that are available. People can quickly click on that and learn what's been done in what jurisdiction, connect up and talk to each other. It's a really sensible, practical tool, but a tool we need to sell. Because, you can do all the work and stick it on the website, and if nobody knows about it, nobody wins. So the next one is to promote and support new entities like the ACDC. It's an acronym, we all know the rock band. Don't forget that the Prime Minister's about my age. He's probably an old headbanger and probably will get quite a laugh out of the notion of leaving behind an ACDC. He'll probably think that's pretty funny. But the Australian Centre for Disease Control is a really fundamental change to the public health infrastructure in Australia, which I hope will last for 100 years. And it's going to be born over the next 6 to 9 months. Really key time to get that right. And finally, the simple message: public health people need to get better at being allies with you. And I encourage you to do some work to become better allies with the public health people, because we're after the same stuff. Thanks very much.
Questions at this point? Got one back up here.
I'll do it, Ronnie, if you like to.
I'll do the running. You do the... Getting prepared.
Thank you for that. It's really nice to see people of power taking some interest. And all those things you're talking about, availability, all those things, they're fantastic but irrelevant for people with mental health issues, because they have no consequence. As you probably have learned from our speaker this morning, for me, public health people, mental health people, they should be proud of who they are, and most likely carers or consumers of mental illness, and speak as consumers, and be part of the consultation, be part of the decision making, not as a tool to help those who don't identify climb the ladder.
Thank you for that. Thank you for that, and I agree. And that co-design notion that we're hearing about more this morning, I know you've talked about over the last few days, is increasingly a dominant theme within the public health world as well. Having people with lived experience of whatever issue you're wrestling with and trying to make progress on is increasingly becoming not only expected but the norm. We're still figuring out how to do that in the most effective, fair and reasonable manner, and there's still more work to be done, but I've got no argument whatsoever with what you say. Our challenge is to be able to do it better. And I think, every day all of us get up and try and do what we do better.
Some over here.
You did ask a question about catching people pre-diagnosis. And I think if you consult with the neurodivergent community, you would find that we all have comorbid mental health issues. And if you want to catch us before we are broken diagnosis, as an adult seeking diagnostic process, the barriers are enormous. They're insurmountable for a lot of cohorts of people, communities who just cannot access it. And without understanding ourselves, we can't speak up about an experience that is affecting us in a way that we don't understand, and quite frankly, you don't understand. Having autistic sensitive treatment is not done. It's barely trauma-informed, quite frankly. So if you want to catch us before we're broken, give us access to diagnostic processes. As adults, as mental health patients even, you can't get diagnosed in an MHU with a developmental disorder. It's on the DSM-5. Why the hell not? We don't want to know that we're autistic because then we become difficult. And therefore we become more broken, have harder time accessing supports. I've actually had supports withdrawn from me because I had a diagnosis of autism. So make it easier for us to be us, access you, and have a weller future. That's what I have to say.
I don't think I can say anything else except yes.
Thank you. That was a really wonderful presentation. I really enjoyed it. As a GP, I'm wondering whether you can enlighten us about whether there's any way forward in terms of enabling people to access GPs more readily in this situation where it's becoming so difficult to find a bulk billing GP, and people with mental illness require longer consultations, which is not well remunerated, and it makes it really hard certainly for people with mental illness, but for everyone. I mean, it's primary care. I think this is preventative of mental illness too, if people can readily see a GP without having out-of-pocket charges.
I know that's one of the first challenges that this health minister has taken on, and Mark Butler's very much engaged in that. And I think he's started coming down that road a little bit in the more recent, probably pretty modest reforms to try and better remunerate primary care and general practice in the first instance has been a step in that direction. But it's a long game, and there's one of the really fundamentals, and you'll be able to tell me better than I can tell you, that simple workforce issues are an enormous challenge. Firstly, the extent to which medical graduates see it as a viable and preferred pathway at the moment is a really fundamental concern. The other concern that I have is that one of the solutions, and it's steeped in national policy at the moment, is to increase the pathway for people coming from overseas and competing for people with primary care skills. But my anxiety there is that we steal the graduates from lower middle income countries, and there's a real moral conundrum with that as far as I'm concerned. Through one of the things that I was doing with a group called the UICC, I found myself at a meeting in Chandigarh in India, and found myself speaking to the chief medical officer of India, who explained the pathway. And it was a long time ago, so I'll get the numbers wrong, but the principle is every year they graduate, I think it was 50,000 medical graduates. Immediately, half of those go into the private sector. And then immediately half of those then go overseas to do advanced training. And then there's another cut before what was left then goes into a system that's serving 1.3 now billion Indian people. All on the basis of the system in India funding the training of those people to become medical graduates. And if Australia's contributing to that and actively doing so and seeking to bring those people, that's a crap solution, I think. So there's an issue about how we better train and then provide a well-remunerated and legitimate pathway into general practice and build in the skills that you were talking about in terms of that training program. So there's a big challenge for the institutions along this strip. How many of them are training medical graduates and in this town, and where they can build that training program to include those kind of issues. But also the health system values and recognises primary care as being an absolute fundamental kind of pillar to our system. I think it's been busted for a little while. And there's big levers that need to be pulled to solve that. And that goes back to the kind of questions earlier about investment in resource. And that big picture story that we talked about with regard to the Treasury and wellbeing budgets. Because we always hear that health is pretty expensive, but it becomes a whole lot more expensive when we get it badly wrong. It plays out in the justice system, it plays out in the court system, it plays out in many other systems as well.
Good closing message. Thank you very much for your address. Lots of wisdom to learn. And I think, as you said, lots of common ground.